Yep, there they are. Perfect. Hey, Josh, how are you?
I'm doing well. How are you guys?
I'm doing fine.
We're good. Yeah, I think so. All right, here we go in 3, 2, 1. What's up, y'all? Welcome to the Sports Medicine Broadcast number 125, Postural Restoration with Mike McKenney and Josh Ogden. They are joining us from, well, Mike's joining us from inside of a snowbank. He is in Northeastern University in Boston, Massachusetts. He was on here about 2 weeks ago. He got his undergrad from Gustavus Adolphus College and his master's in advanced athletic training from North Dakota in 2013. And then he's doing some electrolyte research, and we talked to him briefly about that last time. And then we got Josh. He's over at Baylor. Josh Ogden is the assistant director of athletic training at Baylor University. He's been in the profession about 7.5 years. His name on Twitter is Man Bear Frog or something like that because he went to TCU, which is the Horned Frogs, and now he's at Baylor, which is the Bears. So he's got a master's in advanced athletic training in Baylor, and he's began his PRI courses in the summer of 2014, which brings us what we're actually talking to, postural restoration. So again, we're going to be talking about that with Josh and Mike. I'm your host, Jeremy Jackson. Sitting right beside me is
Jose,
Shakira, Gabby, Jess,
and Matthew.
And then from the University of Houston Masters of Athletic Training program, we have
Matt Barnes,
Dr. Josh Yellen.
Nicole Kasha.
So, Josh, I should have said this before we got started, but it's Ogden, correct?
Correct.
Okay, just make sure I'm not saying it wrong the whole time. All right, so if you want to join our conversation right now, we got 3 people logged in live, sportsmedicinebroadcast.com. Again, you can get CEUs if you're logged in. If you just want to watch, if you're listening to it later, that's fine. But if you want to get the CEUs while you're at lunch, then again, sportsmedicinebroadcast.com. Make sure you register for the email list. That's where I send it out early, the link, so that you can register. Because once it gets to a certain number, then we can't allow any more people in. I think it's 20. So if you want those links, if you want in early, the free CEUs during your lunch, make sure you join the email list there on sportsmedicinebroadcast.com. Without much further ado,
Mr. McKenney, please tell us about yourself.
Just kind of a review from the last time I was on. So I've been in the profession about 6.5 years, going on year 7. I started out in a high school and a clinic physician extender position, went back to graduate school, worked Division I baseball while I was there, also doing the research previously mentioned. And now I'm here at Northeastern University. I keep going to N universities, but at Northeastern, where I work primarily with men's hockey and coordinate the clinical education for our site. We're an external site for Boston University, so I take care of all the students and that we get from them.
Mr. Ogden, please tell us about yourself.
Sure. I'm originally grew up in Northeast Texas and did my undergraduate education at TCU. From there, I attended Baylor for grad school. I worked the baseball program at that time. Took a job out of school at University of Mary Hardin Baylor, where I've worked at the Division III level as well. And then came back to Baylor, where I was originally working with the soccer and softball programs up until about a year ago when I transitioned over to baseball. I have experience with baseball, women's soccer, volleyball, men's and women's basketball, kind of a wide variety of sports, but my focus this time is primarily baseball.
Mr. McKenney, can you define postural restoration?
When I first saw that question, that's a bit of a tough sell, because one of the things that they always talk about in postural restoration courses is it's actually not about posture, which seems a bit odd when you talk about its name, but it's primarily a system of measuring system variability in the human body. And it's an approach to treating natural asymmetries in the body because we're not symmetrical. Obviously, we have, say, the liver on the right side, which is much larger than your spleen on the left, but you also have your heart on the left, not on the right. Your lungs are different sizes and that sort of thing. And working with those asymmetries and how they drive us into patterns. One of the things that it really works on is it's restoring triplanar movement. So it's not just sitting up straight, it's balancing cortical pathways into the left space through neuroplasticity.
So it sounds like that's a really long explanation of kinetic chain.
Sort of. They start with kind of talking about what they refer to as polyarticular chains. If you've ever read like anatomy trains and books like that, they speak to fascial trains and things of that nature. But it's more than just the kinetic chain. It's more the neurological thing before it. One of the things that I always like to tell people, and this is from James Anderson, a great speaker for the PRI Institute, is he's always talking about you have to turn the neurological key first because your brain drives the truck. It just kind of pulls a little to the right, and we'll probably get to talking about that in in a few minutes.
So back when I was going to school, we learned about a theory called ontogeny, recapitulating phylogeny. That's something that I've tried to educate the graduate students on. And essentially that theory is based in the fact that, you know, as a human being becomes a human being, there's certain processes that that person needs to go through. And if you understand the body as a quadrupedal machine or mammal, and then you understand, you know, how now we're bipedal mammals, you would easily be able to identify all these weaknesses in the kinetic chain and, you know, on to postural restoration, et cetera. When I was going through school, we didn't have any of this. You know, we really focused on kinetic chain and that understanding of that theory and kind of working back from there. Can you elaborate a little bit more for those that don't, when you're talking about the neurological pathways, et cetera, can you elaborate some more on that?
So one of the things that a lot of PRI focuses on is that neurological tone and tension. So our brain's asymmetrical to start with. You know, everybody learns that in basic and that in phys. You know, right controls the left controls the right, and, you know, et cetera. But what it's really getting at is the asymmetry of how the brain finds is your home base, what position your body is basically naturally in. And that's more what the PRI approach is about, is, again, that neurological starting point. And kind of like the sympathetic output is basically sports, to be honest with you, and that's kind of what we're trying to manage. So that sympathetic response to threat. So Josh works with baseball, and he can talk with this. So when a batter is, you know, basically up at the plate, that sympathetic response that the body treats as threat, that batter is harnessing to basically hit the baseball. So that's really where we're working. And I know Josh had some comments on how it's not just sitting up straight, and kind of speaking to that as well.
Right. And to kind of speak on that as well, what you're saying about the transition from the quadrupedal animal to the bipedal, that leads us into, as PRI would say, a lot of extension tone, or a lot of sympathetic tone. And we need the extension tone to stand up and be a bipedal animal. Where we run into problems with the PRI perspective is going to be too much extension tone, or unequal extension tone on the right and the left. And that's where you get into, you know, postural compensations or pathocompensatory patterns that are going to lead to problems going forward.
Okay, well, that, I mean, that all makes clear sense if you understand the basic premise of kinetic chain.
Yes.
Mike, you missing the papers over there?
Yeah, so part of PRI is notes. So I just want to make sure I keep myself organized, because this is a more advanced topic. But one thing I wanted to add is more like one of the things that we talk about with the neurological approach is that, so when Josh talks about that sympathetic drive that takes us into extension, that's a response before you even think about posture. That's your reticular formations autonomically driving that sympathetic tone. So that's when you get into a little bit more in depth into some of the PRI material. They don't even talk about body position. They're just talking about how your brain responds to threat. Eric Otter's done some really great talks on referring to it as the lion that comes into the room. And this lion, obviously, if a lion comes into my room right now, I'm going to freak out, and it's going to drive sympathetic tone. I'm going to run away. And it's about that lion following you around all day. So it's basically not just sport. It's how your brain is keeping your body in a kind of a home-based position throughout the day. Again, irrespective of, you know, where your hips are, your glutes, you know, diaphragm, whatever. We'll get to that. But again, it's what's driving the truck.
I'm sorry, how much of this research has come out of the military and dealing with special ops?
I don't actually have a good answer for that. I know when you look at a lot of the research, a lot of people say, oh, there's no there's no research on PRI, and it's because they don't actually use the words PRI. They, you can look at, neurophysiology, kinetic chain, and things like that. But there are definitely research articles out there that we're starting to see that, reinforce some of these concepts. And especially now when they're doing a lot of heart rate monitoring with special forces and things like that, to see where this sympathetic tone comes from, because obviously you need those guys to perform at a high level with
regardless of fear, regardless of sympathetic tension, regardless of neural input. You need them to be able to complete a task.
Yeah, right. Obviously the stakes are high in like sports, but the stakes are far much greater in the special forces situation.
Kind of touch on that topic as well. I've seen very limited research with PRI named. There is quite a bit of research coming out that shows the sympathetic influence on like visual changes pre and post injury, heart rate variability pre and post injury, those kind of things. They're all they're not necessarily PRI by name, but they all tie into the whole the neurologically driven response to the sympathetic and the parasympathetic nervous system. And that's those systems influence on the entire organism.
So not to downplay PRI, because obviously all of its concepts are very important, but what it really sounds like is that PRI is there to essentially put a name to all these physiological phenomenons that we're seeing. Is that correct?
Yeah, it's an approach. So it's kind of like looking at the system from a different angle. Some other systems that can coexist with it, if you've been familiar with DNS, is also something that's used. Again, that developmental, like you were talking about, the development of the human, quadruped, bipedal, and triplanar movement is themes also found in that as well. And DNS has been around. I don't know the exact history of it, but it's again similar.
Okay. Have either one of you heard of the term and/or concept tensegrity?
I have not.
Yes, I have. In terms of the basically the tent model, correct?
Right. How the body is kind of held together through tension and
basically a three-dimensional modeling of the human body, right?
Right. Do you guys apply that in the PRI? Is that something that's kind of considered when you're kind of doing the PRI approach?
I would say I don't apply it directly in terms of evaluating a tensegrity model, but tensegrity as a whole it's a way of looking at the entirety of the chain or of the system. And if one part of that chain breaks down, it's going to lead to compensations and lead to potentially problems in another area. And so for me, yes, I do. When I do a PRI evaluation of somebody, I evaluate everything from the feet to the cervical rotation. And so for me, it is kind of a total body approach. So I wouldn't say that I do a tensegrity evaluation, but I do try and look at the entirety of the individual.
All right, so I got a quick question. Honestly, I feel a little overwhelmed here. I feel like there's a lot of terms that I don't ever use.
A lot of these big words with a lot of consonants, and nobody knows what's going on right now.
And so, Josh, I'm gonna ask if you can kind of break this down to maybe like a high school or junior high type level. Maybe you were talking to your freshman athletes and you're trying to describe what you're doing, but can you try and break this down? What we're talking about here?
And can you please use Crayola and diagrams, please?
Sure, I'll do my best here.
Thank you.
The tensegrity concept, that is basically if you have, let's say, take the example that you're out camping in the woods and you have a tent that's made up of multiple poles, right? If one particular pole in that model is out of place or is not doing its job, it refers that stress onto another pole. And if enough poles, or in terms of the human body, if enough muscles or joints are not doing their job with the proper mechanics and the proper approach, eventually one of those other poles is going to break. I think does that sound like a good tensegrity breakdown?
One of the best analogies that I heard for tensegrity was with the cell model, just a basic cell model. It could be a plant cell or just an animal cell. but within the cell, it's not held together, and it's not its structure is not put together like stacks, like you would put like build a house, just stacks of bricks. They're held together, and its strength comes from the tension that's within the cell and the cell wall. So you have like the plasma, and if some sort of amalgam is found inside the cell, then it'll just kind of like just lose its structure, lose its like basic structure. So that's like one of the best analogies that I heard with just basic cell.
So to answer your question, yes, describing it in the form of the tent, describing it that way, that makes sense there. But how about with the PRI stuff? Again, I teach high school. I'm not used to using really big words, and it's been a long time since I've been in college. So, Mikey, can you give it another shot in dumbing down the PR, or not dumbing down? Whatever. Just define it.
Repurpose some of your statements.
Translating there, repurposing.
Sure. Okay. So I think what usually helps athletic trainers that aren't necessarily familiar with these yet is when we actually add the biomechanic component into it. So when you talk about what Josh was speaking with the tent in the three, something's going to produce tension here, here, and here. PRI goes farther and basically starts with telling us why that tone, that tension, those things that are causing pain in athletes sometimes are existing. One of the things that these patterns we were talking about, what we call a compensatory pattern, is based off the asymmetry in the body and what that home base is. So when you hear a lot about PRI, you hear a lot of talk about the diaphragm, this huge muscle basically in the center of your body, your center of gravity, that has a large influence on body position and how we're trying to use that to move the body around. But the problem is the two things that we're trying to address is limits and variability and movement freedom. You lack movement freedom, you limit variability, that's when you start to see injury. I know there's a big talk now, you start hearing it a lot with how many quarterbacks in the NFL now didn't play just football. They played multiple different sports, had different demands on their body, they had variability. And these specialized athletes you're finding are getting hurt more because they don't have variability. They're always doing the same thing over and over again, year in, year out. Not say maybe playing an overhead sport like, I don't know, tennis, and then going playing soccer with totally different demands. And so that's kind of what that's its starting point. And then once you get away from that starting point, that's where you start getting into how does this apply to sport? How does it apply to the general population? So that's again the starting point.
So PRI sounds like it's really developed in its roots from a holistic approach, probably from an osteopathic perspective. Is that correct?
Yes. In fact, some of the techniques you might even find in the Greenman text, which is an osteopathic medicine textbook. But again, bringing a lot of theory together, that is what Ron kind of did in the 90s to build the PRI Institute.
And can you go back real quick? I'm sorry, Nicole. Yeah. Can you go back real quick can you give the audience a little bit of history perspective about PRI? Because a lot of people listening to this would probably say, okay, well, I've heard of these theories independently of one another, but I never heard of something called PRI. So can you elaborate on what does PRI stand for? When was it developed? How was it developed? And why is it gaining traction now?
So Ron Hruska is the founder of the Postural Respiration Institute. And about, I think the start date, they said when he was putting all these ideas together and finding all these theories was about 94, 95-ish.
And what's his background?
He's a physical therapist. And it's based out of Lincoln, Nebraska. And they were taking these theories and building upon them. But the problem is sometimes a lot of these theories are at odds with what we're taught traditionally as athletic trainers, what physical therapy is taught traditionally. And so there's a lot of pushback to a lot of these theories that I think it's gaining more traction now, because now we're starting to see that maybe these ideas weren't so outlandish as they were treated originally. There's a lot of traction to them, and we're finding application for them, and we're making people better. And also I think it's gaining traction because a lot of Major League Baseball teams are finding use in it. NFL teams are starting to use it. It exists in hockey, the NBA. I mean, so these bigger organizations are starting to say, hey, we're treating our athletes and making them better with this. So I think it's starting to gain traction in that realm. But there's still
I'm going to throw something out here, right? And I'm going to throw a modality that we're all familiar with. I'm going to say, hey, look, the Hivamat has shown, empirically that we're seeing some benefit of the Hivamat, but nobody can really break down theoretically why it works. There's some postulations, static electricity and lymphatic movement, but nobody really has a clear understanding. It sounds like PRI, and not to downplay it or take away its importance, but it sounds like PRI is along those lines, that we have all these physiological phenomenons and that we're using it, we're seeing some benefit, but I can't really identify exactly why it's happening.
Mm-hmm.
Is that a correct statement?
I would answer that in saying, in some of the neurological applications, like one of the courses I attended was a PRI vision course for baseball. Some of the neurological implications of the vision integration, yes, absolutely. In strictly, orthopedic terms, I would break it down in, it all relates back to center of gravity. So one of the, Mike was talking earlier about the anatomical chains in the body. With what they call the left AIC chain, you get an anterior hip tip of the left pelvis. Well, then that, above and below requires compensations both in internal, external rotation of the femurs, in orientation of the spine, orientation of the neck on the shoulders. A lot of it breaks down in terms of center of gravity. And if you get that skeleton into I'd call it a neutral center of gravity, I think that explains a lot of the postural changes that we see immediately, strictly from an orthopedic type standpoint.
Yeah. And to go one step farther than that, and again, some of the neurological stuff, that can be difficult to see, research to prove that. But say if we're treating an athlete with an annular tear and a disc in, say, his lumbar thoracic region, and I get him into a better position with these treatments, he's in a better position. Often the surgeon doesn't care how I got him there. It's that he's staying there and he's out of pain. So that's where, again, in our setting, I think we see a lot of benefit from that is, those hip patients, those back patients, those chronic groin pain patients that just learn to live with pain instead of trying to fix it.
So when you were saying center of gravity, I immediately thought the diaphragm. Now, I've read some of the anatomy train book and I've seen some of the pictures, and somehow it always kind of reverts back to the diaphragm. Do you think maybe that correlates the center of gravity and diaphragm?
Absolutely.
Yeah, definitely. So one of the things I wrote in our notes here is part of it is lining up your hips, your head, everything in line. But so Josh mentioned that left AIC pattern. So one of the things to understand about the diaphragm's asymmetrical. The right, it works better in a domed shape, and the right side of your diaphragm is in a more efficient position because it's sitting on top of the liver and has that domed shape. Your left diaphragm actually develops, in utero and as you grow flatter because you have the heart sitting on top of it. So its mechanical advantage is inherently different than the right, which leads to, so the right diaphragm controls the left chest. It's more efficient. You have this flared left rib cage. And what that does is that makes the left diaphragm incredibly inefficient. So now your right rib cage isn't functioning the way you would like it to. And this is what we see in athletes a lot because they have to undergo these demands of, okay, if I'm going to make somebody run, sprint, whatever, they need lung capacity. So they end up working themselves. And you guys are all around athletes daily. You've seen these athletes with an anteriorly rotated pelvis forward, both ribs out. And then they're in that extension pattern. And that's where, underneath, there's that asymmetry to the right because the right diaphragm's more efficient, but they adapt trying to come back to the left and they find that movement everywhere else. And they usually, in some cases, it creates quite a bit of problems for the athlete.
Yeah, so it's just breathing techniques, probably for restoration of the diaphragm, right? Like inhalation, exhalation, practicing, but like in proper spine position too.
Yeah. Josh, you want to answer that?
Sure, I'll touch on that. Yes, in the PRI, Postural Respiration Institute, offers 3 basic level courses, one of which is their Postural Respiration that deals with what Mike was talking about. in terms of the internal externalization of the. I see it. I love it. Mike's showing the manual here.
Oh, I thought that was the Crayola diagram that he was drawing for those that.
That's the course that deals with the breathing techniques, and they also offer some manual techniques to engage with the left half of the diaphragm. But yes, they do. One of the techniques that I love is inhale through the nose, exhale through a balloon for several sets of 4 or 5 breaths.
I'm sorry.
It really
go back again. Inhale through the nose and exhale through the what?
Balloon.
The balloon.
We actually do that daily with our baseball team.
Yeah. Okay.
Yeah,
I thought you
we're
said
doing that
something
with
else.
the
I didn't understand balloon. I thought it was something else.
This isn't it's an actual balloon, not a metaphorical one, right?
Yes, literally.
Okay.
I use party balloons.
Yeah.
All right. Good. Go ahead. Continue. Just make sure I understand.
But breathing out with resistance, whether it's in a balloon or a straw, it forces the individual to engage the internal obliques, the transverse abdominis, the spinal stabilizers, and really in doing so create, I think Mike can put in his notes, we'll probably get to in a second, restore what's called the zone of apposition or proper diaphragm positioning. But being able to engage the obliques for exhalation really helps to, I guess, bring that left rib flare down where the left half of the diaphragm can dome up and become a respiratory muscle as opposed to a postural muscle.
Exactly. And that's what I was going to just, Josh beat me to it. So you've got your right side's acting for respiration, your left side's acting for posturation or postural, movement. And that's where we get that dynamic asymmetry that creates a lot of problems. And so what happens is, since the left rib is flared, that mechanical advantage is almost passively insufficient for the diaphragm, and it can't pull on its central tendon like the right side does. And then you create a lot of problems with that. A lot of the ways we treat this is by having athletes lay supine with their legs up at 90 degrees, and they have a posterior pelvic tilt only with their hamstrings with relaxed abdominal muscles. And in that position, you can call it J up and L whatever, because if they go into extension, you're going to reinforce what we're trying to fix. So if you get those ribs down, then the diaphragm is going to function more efficiently.
So I'm sorry to interrupt. Go ahead.
No worries.
So it really sounds like, the inhale through the balloon, inhale through the nose, exhale through the balloon. If I go back to, somebody that's coming out of surgery, and one of the first basic exercises they need to do is with the spirometer. Right. This is the same concept. I mean, really, the spirometer is there so we can move air, in and out, and people don't, have some sort of thrombosis. But really, the exercise that they're doing is exactly what you just described.
I'm smiling because it's interesting you mentioned a spirometry. We actually have a system here called the Pro 2, which is where you it's a spirometry type system, but electronic, where you blow into it, it records it on a tablet and software, and gives us a lot of the same information. We're actually finding with PRI treatments here, if we improve that diaphragm function, if we improve rib mobility, we get their spine out of extension, we actually see immediate increases in tidal volume, just overall lung capacity. So it's along those lines. We're definite, and I can tell you pretty much every single post-op patient we get's doing this as soon as they get back in my immediate care.
Okay. Along those lines, so go back to rib mobility, right? I'm going to take the osteopathic perspective. When I was in graduate school, I took 6 hours of osteopathic electives. I was in California at the time. And so along those ways, right, you look at biomechanics of the spine, biomechanics of holistic movement, and you get into manipulation, mobilization, etc. How much of that is incorporated into both your practices? I can imagine, Josh, you dealing with baseball, you're constantly doing some sort of mob manipulation with the scapula, upper thoracics, that kind of stuff. So include that in some of your PRI training, and then also talk about some other methods of assessment that you all use, FMS, et cetera.
I guess in terms of integrating with the PRI, whether it's for rehab or, daily treatment or evaluation, I kind of integrate the standard orthopedic type stuff along with the PRI. Really what I've found with doing some of the PRI, what they call non-manual techniques, is it really reduces my need to do any of the mobilizations for the scapula for scapulothoracic function. When I get restore the zone of apposition and get their spine back into a normal alignment and get them into what PRI considers neutral, a lot of them I need to do the manipulations and some of the osteopathic techniques like that to maybe increase internal rotation. That's really reduced. When I get them into neutrality, there's almost, in some cases there's a need, but by and large, the internal rotation deficits that I've seen before, the scapular positioning, malalignment type stuff, that takes care of itself.
And out of curiosity, do you have metrics to back this up, or is this something that you're seeing clinically and you can't report on?
A little bit of both. Over the summer, when I was learning the PRI stuff, I came up with a standard evaluation form that includes both some standard orthopedic measurements, internal external rotation of the hips, plantar flexion, dorsiflexion of the ankles, thoracic rotation, internal external rotation, elevation, abduction of the shoulders. And I do have the numbers it's primarily been pitchers that I've worked with on this, that have backed up, the changes seen from initial evaluation on post-evaluation a couple weeks down the road. But in terms of like actual measurement of, scapulothoracic positioning, just the way somebody looks, not necessarily. And I do have some pre and post pictures with the Alana body, the grid system. But obviously I can't, really go publish those without patient permission. But I do have some of those that show, just the postural alignment changes seen after a couple of weeks of treatment.
So do you believe that you have to have initially first good qualitative analysis and then you can get your quantitative analysis?
Ideally, yes. But I think clinically, there's always going to be the component that I absolutely want evidence-based medicine, evidence-based sports medicine, but there's some of the things that I see in these patients that I don't necessarily know how we're going to be able to get the hard quantitative data, especially in like a randomized controlled setting. And qualitatively, I want positive patient outcomes, and I can definitely state that I've had positive outcomes from utilizing the PRI techniques. In terms of the hard quantitative data, I'm hopeful to see that come. I just don't know how in my setting, in my specific facility, how I'm going to be able to do that.
Yeah, well, I was thinking to be able to obtain any good quantitative data, you'd have to be able to evaluate qualitatively, like properly.
So to kind of jump in on that, so PRI uses, and I kind of talked about this with Dan when we last talked about the podcast about using systems like FMS and SFMA. We use SFMA a lot to have that immediate pre-test, post-test. So I can test somebody from a movement standpoint immediately before treatment, go through a PRI treatment, and all those dysfunctional patterns have righted themselves. PRI has a lot of that too, where they have their own tests that are actually some modified versions of things you learn in school, like the Ober and Thomas test, that basing your evaluation off those, you can see immediate gains. So it's not just saying, okay, do you feel better, yes or no? That's important. You want to know that with your patient, but you can actually show them and have them feel movement improvements. So I at least know with our utilization of SFMA and FMS here, we've got people that maybe with, like I work with hockey, so hip problems are a way of life essentially. So if they're lacking hip mobility and they can't do certain functions in the FMS, we pull them out of the FMS, go through these treatments, send them right back into it, and their numbers improve. Or if they're SFMA, we do a breakout that was used to be painful or dysfunctional. Now it's pain-free and functional. We've got immediate pre and post tests. Now that's not necessarily numbers on a goniometer, but
well, on a pain scale and a functional scale, they've increased.
Absolutely.
And
that's
sustainable. So my question to you is this, right? So I'm treating a patient in, in clinic, I'm doing the FMS, and I see that they lack mobility and function in a certain area of movement. I pull them out. I introduce this intervention. I put them back in, and the numbers have improved. Those numbers are sustainable, or they're constantly coming back to me, and I'm saying, hey, listen. I suppose the question is this an intervention that constantly needs clinician participation, or is this an intervention, the PRI I'm referencing, that can be used, and over time that athlete needs to be able to rely less and less on it, so it's a sustainable intervention?
Yeah, so Josh kind of mentioned some of this with the they have what are called non-manual and manual techniques. Manual is like me working with an athlete, guiding their rib cage as they exhale and things like that. Non-manual is rehab, essentially. Hey, here are your exercises, go do these. And PRI actually has an approach. Again, we want to work on neuroplasticity. We want to teach the brain and the body to be in a better position all the time, not just when you're doing rehab. So the non-manual techniques are always taught to be done first. You're training that athlete. You're training their brain to move themselves a certain way before you kind of have to give it help. So that's the goal from the start with PRI treatments.
So going back to patterns and functional patterns that you're talking about,
yes.
How important do you think a biomechanist would be for an athlete, or just in general for PRI?
To be honest with you, I think the biomechanist would be less important than if you want to deal with a neurologist if you're dealing with PRI, because again, it's that neurological approach. So neurological rehab and things like that. The biomechanist, I think, as athletic trainers and physical therapists, have more than enough knowledge to apply and integrate PRI into their treatments, where a specific biomechanist will obviously have really good insight on how the body's positioned, but not necessarily why PRI is working.
Mm-hmm. Right. And to kind of touch on that myself, really, I think to combine those two, if you did a biomechanic analysis, did a PRI intervention, and then put this individual, let's say in my case, a pitcher, put them back up on a mound, as soon as they get their spikes on, their glove, ball in their hand, ball cap on, they're going to, neurologically, they are wired to be in the position that made them an effective pitcher in the first place. So as soon as you add those things back in, you put them back on the mound, that neurological hardwiring is going to kick right back in. So in terms of a short-term intervention, in a biomechanics setting, it may look like there is no change after a couple of weeks of this intervention, where they've gotten used to living in this pattern, in neutrality, away from the field. I think you are going to see a change. But I think that the positioning, the patterning is so neurologically hardwired initially that it's going to take 4, 6, some cases 8 weeks to really get them used to living in neutrality.
And in some cases, like what Josh said, I don't even want to break that. If you look at the example they always give in PRI is Usain Bolt, because you look at this guy with rib flares who's basically breaking world records running in a straight line with not a lot of variability in triplanar movement. I don't want to, quote, fix him with PRI. I'll make him slower. Mm-hmm. That tone, that extension pattern is why he's a world-class Olympian and gold medalist and world record holder. So in athletics, the deck is stacked differently than, say, the general patient population. Mm-hmm. In general patients, neutrality is probably very ideal. Someone sitting at a desk in pain their whole life wants that to go away. But we are in a setting where we need athletes, and this is what me and Dan were talking about, and I think what led to this discussion here today is we need to manage this for performance. Performance is healthcare, and this is where our role as an athletic trainer impacts that directly.
So in the athletic training setting, using the approach of PRI, how and when do you know, like, when it's appropriate to actually implement PRI for an athlete that may have some malalignment, but for some reason it's actually functional for them and the performance?
So I'm smiling because I always, the answer is always or yes.
Right.
Obviously I deal with a high injury rate contact sport. So I've got things that happen regardless of PRI. It doesn't matter. It's contact sport, but there's a lot of chronic issues that if someone's coming into me saying my right adductor is fired up, I don't know why, I didn't do anything, I'm immediately looking at a PRI approach. And some of the back patients I've been dealing with lately, I can honestly tell you I wouldn't have been able to treat prior to, getting integrated in this approach. I would have just run into a wall and not been able to help them. But by realizing where that alignment is, I can fix it, and I can use their body. I can teach them to live in a better position. Now, Josh talked about pitchers. The second they put that hat on, all right, extension pattern, I want to go back into what makes me throw 94, 95. And this is what I talked about earlier, that quote from Eric Otter is, so that pitcher turns into a lion. Now, when that pitcher walks off the ballpark or my goalie takes his helmet off at the end of the day, we got to make sure that lion goes back in the cage. So
right, absolutely.
Basically, Eric Otter, he put it great. He was like, so the lion doesn't follow you home.
Mm-hmm.
And that's where and that's kind of like, I know, like when you talk about gait mechanics as an aside, like this is why I hate flip-flops, especially for hockey players, because their whole life is spent midfoot, forefoot. Mm-hmm. They don't use their heels when they skate. Mm-hmm. So if they stay in flip-flops when they come off the ice, they're not stopping skating as they walk around because they don't use their heels. And so they're living their whole life in a hockey position. So they're constantly grinding their neurological system down to where it's going to go into dysfunction. So again, teach them to take that switch from on to off enhances their recovery and hopefully eventually lowers their injury rates.
All right, Josh, I want to ask you a question specifically geared towards baseball, and I want you to give me an answer where you've used PRI to address this. So, baseball, obviously, just like any other sport, comes with some inherent injuries, but one of the injuries that we see most often in baseball players that a lot of other athletes don't encourage just because of the motion is, this first rib elevation, tight scalenes, tight respiratory movement. So apply PRI and address that particular pathology without using mobilization or manipulation as you described before.
Okay. In terms of addressing the first rib, the scalene tightness, that kind of thing, I don't know if I can truly address that without some kind of mobilization or some kind of manual techniques included. But yeah, that's absolutely a really common technique for us. A really common problem for us. In terms of addressing that, I would integrate some of the PRI, some of the breathing exercises, in terms of restoring left zone of apposition so that they can fully inflate the upper right lung, which really helps to release some of the tension in that area. I know it's very common in a right-handed pitcher to see the depressed right shoulder, the neck over to this side, kind of, I don't want to say pseudo tension because there is tension there, but it's tension due to a postural issue. So using the PRI techniques, I help this individual to fully inflate the upper right part of their chest, essentially. And the way I explain it to my throwers that have this kind of an issue, basically, we've all, for years, we've all been taught the scap is the foundation of the shoulder. But the scap sits on the rib cage, and if the rib cage doesn't have a solid foundation of lung expansion under it, you're going to have issues with the scap. And if that's malpositioned, you get the kind of the lateral movement, the anterior tip of that increases the stretch on the scalenes. So basically, through the PRI techniques, I want to work on fully inflating the upper right chest cavity, and along with that, get them to activate their right low trap, the right serratus, that kind of stuff to bring that scap back into the natural positioning. When I do that over the course of a couple of weeks, you see that that dropped shoulder, gradually start to come back into position. One of the things with the PRI chains, I guess, the left AIC, right BC chain that we talked about a little bit, they get kind of the drop here in the rotation. So I want to bring them back into a position of neutrality. And when they can then fully inflate the right upper chest cavity, that's going to help to, help to increase first rib mobility and take tension off of the scalenes. Along with that, there are some manual techniques that I use, some PRI manual techniques, one of which is Simpson's fascia release. One is a first rib subclavius release. But I don't think that I can fully treat that problem without doing the manuals.
So you would use PRI in adjunct with like a MOB or any sort of.
Yes. The MOBs that I'm talking about are actually in the PRI course material, in terms of a subclavius release, Simpson's fascia stretch. There's also techniques. You can go look in a Greenman text that Mike mentioned earlier, and he has techniques for subclavius release that would work just as well. But I think that in the case of a tight subclavius or scaling tightness, I think that manual techniques are pretty well required.
And something I want to add to what Josh said. So when we talk about diaphragm breathing techniques, it's not belly breathing. There's a big understanding that people think if you breathe with your diaphragm, your stomach moves first. Your lungs aren't in your stomach. And so what Josh is talking about, if your rib cage isn't moving, you need that to move in order for your diaphragm and lungs to work properly. So now you'll eventually have that dome, that rib cage, abdomen, but it's not stomach ribs, or just stomach only, because the ribs are so locked down, there's no movement in that first rib.
So you can pretty much agree that PRI somehow teaches the body that proper patterns are important.
Yes.
Yeah.
Versus functional, because some.
Yes.
Yeah.
And Mike mentioned that when to integrate PRI. In his case, always. In my case, if they have problems, always. If there's something that I've picked up on biomechanically, posturally, whatever, the answer is always, but after activity. One thing that I've found, especially with the manual techniques, is if I put that person into a position of neutrality before activity, all of a sudden my pitcher, that had an internal rotation limitation, or had a front hip limitation, something like that, those biomechanic compensations may be gone, but that young man can't throw strikes. If I reposition somebody before they go out, they may throw 2 or 3 miles an hour harder, but have no concept of the strike zone because they're now in a position their body's not used to. What has made them a great athlete is that compensatory pattern. And I don't want to take that away from them before competition, because that's going to negatively impact them on the field. Over the long term, I want to address those so that we don't get the long-term pathocompensatory problems, the posterior labral fraying, the rotator cuff fraying, subacromial bursitis, biceps tendonitis. I think all of those things are direct results of the compensatory patterns that we see.
So what about anterior glenohumeral head laxity?
And can you repeat that? I'm sorry.
Anterior glenohumeral head laxity, or you have that the humeral head just comes forward.
Just slides forward. I honestly don't feel like I see that a ton and I work with a limited population. Obviously, I have 35 athletes, and 17 or 18 of those are pitchers. That's kind of a compensation to fake the internal rotation, I guess. If the scap is brought anteriorly, they're going to be limited in what they're able to do, especially in external rotation, because of the glenoid positioning. So you're going to have some ligamentous laxity, some capsular laxity in order to fake the range of motion that should be there naturally.
And we actually see that a lot. It's interesting you mentioned that with the shoulder. So moving to another ball and socket joint, and PRI, you see that a lot with the hip, where we haven't restored to anybody, and we do a modified Thomas test, and their leg falls straight to the table, and they're complaining of hip flexor pain. Mm-hmm. That's not hip flexor pain. That's lack of an anterior, that's anterior hip capsule laxity. And then our goal at that point is now, how do we get all the muscles around the hip to basically function as that capsule, the ligamentous laxity that they now have, we have to pick up, with muscular movement.
So can you guys, switching gears a little bit, can you guys elaborate a little bit more on some other therapies or adjuncts that you may use in conjunction with PRI, as a synergist? So how often are you using, obviously FMS is a way to evaluate some structural deficiencies, but if you guys are using Graston, A-stem, ART, myofascial, in conjunction with the PRI? What kind of success rates are you guys seeing?
So one of the things that we always teach is, I think Josh made some notes on this too, and he can definitely talk about this, is are you treating tension, tone, or adhesion? And if we use PRI to take that tension and tone, so before, let me back up. Before I do a manual treatment with somebody, they always do PRI techniques, always. Because if I have a bullseye this big because of tension and tone and the position of their body, and then I have them do non-manual techniques, then they make that bullseye this big, I have a much easier time treating that person and giving them an effective treatment. Because I'm not saying that adhesions don't exist. I mean, obviously, if they've been in a position for years, they're shortening, we do have to address those limitations. And then I'm particularly trained in the fascial abrasion technique and use some other techniques with that Spina pioneered, like functional range release and things of that nature, and then some other joint mobilization techniques, which honestly, once you get some of that tone and tension away, joint mobilizations are actually going to be more beneficial for you.
Okay, so go back to the question. So what some of your clinical application, can you give us some real life scenarios of where you've used these different techniques in as a synergist to PRI?
So one of them is major ACL, a major ACL reconstruction, because there's lots of other additional damage to the knee as well. That you've got a patient that was a previous patient for other problems in the hip. His knee wasn't even the problem. And part of the problem was these fascial techniques trying to address, issues in the glute med, issues in the TFL. Since, by the way, I don't think you can stretch the IT band. There's no such thing as a tight IT band, and I'll stand by that pretty firmly.
Yeah.
I'll agree with you on that one.
Yeah, you can't stretch the IT band, so stop trying. That's all athletic trainers listening. Stop it. But all these things aren't working, and then when we back up for a second, and we're like, okay, well, I need to address some adhesions and limitations he's got in his rectus femoris, but his pelvis is all over the place because we've got now arthrogenic muscle inhibition from a postoperative knee surgery, the patterns from years of hip problems in soccer. Now we've got to fix those problems before my techniques are more effective. So it's kind of getting along the lines of, if you need to treat tissue, you have to warm it up first or get it to a therapeutic range to increase the extensibility of it. If I need a fascial technique like the fascial abrasion technique to work, I need to make sure I'm working with the actual limitation in the muscle and not a positional limitation. So I'm removing positional limitations. And that's just also a basic manual therapy rule. Don't put them in a position.
That's manual therapy 101.
Yeah, exactly. And that's, and again, the fascial abrasion technique is a relatively new technique. It's from the Fit Institute. So it's not necessarily grasped in. It's more of a pulling and tugging, not a scraping type of technique.
So
I would say, along with that, I'd say that the PRI stuff is kind of a global repositioning technique. And, if you restore their neutral position of the pelvis, neutral spine, neutrality through the shoulder girdles, and then they still have a localized problem, in my case, say in a bicep or forearm tightness, something like that, then in that case, I know I'm probably dealing with a localized problem. And I use, obviously, hands-on massage, some ISDM stuff, in some cases do some suction cup massage techniques. But I try and deal with the localized problem after I've addressed the globalized, problems of asymmetry.
I want to ask Josh a question. When's the last time you stretched a posterior capsule of the shoulder?
I have a lot of guys that think I do that every day, but really not that common.
Bingo.
Just taken for a posterior mode, right?
Sometimes. After doing, honestly, since learning the PRI stuff, I've completely changed my approach to stretching shoulders. And, I may do, most of my pitchers have done PRI at this point, and the internal rotation deficit that they had at one point, of going to a physician and being told, you need to get 15 to 20 more degrees internal rotation, blah, blah, blah. To me, that limitation doesn't exist anymore. Because once you get the alignment correct, the internal rotation deficit takes care of itself. So what I do in terms of posterior capsule or internal rotation stretching, that stuff, is to maintain what that individual has. And with a couple of my pitchers at this point, it's gotten to they want me to stretch them, and I can't in good conscience stretch them into internal rotation because I'm worried about creating an MDI, some other issue.
Yeah, and that's one of the things that with like I say, there's no such thing as a tight IT band. It's just if I do an Ober test, which is called the adduction drop test in PRI, and they're flat as a board, I can go through 4 or 5 basic breathing techniques, and all of a sudden their knee just falls right to the table. I never touched their hip. What he's talking about is similar to what they have glenohumeral internal rotation supine, and how we can improve that by improving the quality of movement in the ribs and right apical expansion in your lungs. And I think that's something that it changes your approach to athletes. Like we have baseball here too. I don't directly treat them, but if they ask me to stretch their shoulder, I'm just like, let me show you something else you can do. Take them through those non-manual techniques and show them that it improved. They're like, oh, well, that's easy. Then I don't need to come see you. I can just do these techniques. And it's like, yes, you can take care of yourself. There's a way you can teach your body to do it.
So if someone has a tight, like if you have your agonist and your antagonist, if you had a tight hamstring, would you activate that antagonist instead of stretching? Or what's your philosophy on stretching?
Not necessarily from a PRI perspective would I go, agonist, antagonist. But from a PNF perspective, yes, that absolutely works. Reduces hamstring tone.
Yeah, and it's that tone. Tone's that dirty 4-letter word in PRI. If you have tone, you're going to have restriction. And it doesn't focus as much on, say, origin insertion. What does the muscle attach to, and then start treating, in that, in that realm. PRI does. They usually always do a demonstration at their courses where they have someone stand with their back against the wall and their lumbar spine flat against it, and they bend over to touch their toes, and they find someone who can't. They say, oh, I've had tight hamstrings for years. And they go through basically just some basic breathing techniques. And you watch as they breathe, they keep going farther and farther and farther. And I've actually watched somebody touch their toes who hasn't done it in 30 years, just because they're living in that position and with that tone. And so, again, we change that body position. I'm not treating a hamstring problem anymore. I worked with track a lot last year in the spring. In our off season, and that was my life, was hamstring problems. And once we were teaching people this almost as a recovery tool, I maybe treated 2 people for like legitimate textbook strained hamstrings.
Right,
yeah. Black and blue.
So give me an example of when you would not use PRI.
Right. Well, I wouldn't try to restore somebody, say right now. In our season, we're 2 weeks from playoffs, like Josh was talking about, we can break somebody in their athletic prowess by fixing them. And we're not really fixing them. So I wouldn't do that now. Also, you'll find, so say if somebody, and I had to do this with someone who had a proximal avulsion of their hamstring, I can't have them in a 90-90 position activating that hamstring because they had a repair. So you need to work within those guidelines if you're dealing post-operatively. Or fractures, someone's got a rib fracture, PRI is not going to be fun, or a clavicle fracture. First rib, clavicle injury makes PRI extremely difficult because of pain. Pain is, now that lion's back in the room, we've got pain, we've got threat. You can throw all PRI out the window because it's not going to stick until you get that under control.
So back when I was in school, right, when I was taking these electives, essentially, what I was taught was we're going to address some of these problems to the extremity. We're going to have to remove the extremities. So we're going to take away the humerus and the radius and the ulna. We're going to take away the femur, the tibia, and the fibula. And we're just going to address that, we know as core, anywhere between, the occiput all the way down to the coccyx. And we're going to address all these different types of issues first, and then we're going to put we're going to put these extremities back on, because if you really look at the extremities, they're duplicates of one another. Going back to that quadrupedal theory.
Yes.
And that really sounds like that's what PRI is capitalizing on, is that I'm going to remove, the extremities. And the theory behind this is that I'm going to address some, what I consider either lack of strength, lack of movement, lack of function, lack of, I guess, variability within movement. And I'm going to address that first. And the theory behind that is that alone will help some extremity movement. Is that really what we're talking about?
Yes.
Okay.
In the PRI for baseball course, in the discussion of the pitcher's mechanics and throwing motion and all that, this exact topic was brought up. And James Anderson, who Mike mentioned earlier, was teaching that course. And his position on it is essentially, we're not treating a shoulder, we're not treating an elbow, we're treating a pelvis and a thorax. Mm-hmm. And if the pelvis and thorax are taken care of, the rest of the appendages should just come along for the ride.
Okay,
and
so really, if you understand, the basic theory behind osteopathic medicine, you understand the basic theory of holistic treatment of the body, then you understand PRI.
To some degree, yes.
To some, yeah. I mean, not the entire thing, but 85% of where it's coming from.
I would say so, because it's rooted in osteopathic medicine, osteopathic techniques, and that approach to treatment of the human body. So I'd agree with that, at least to some degree.
Yeah, and that's a great visual I think you gave, is that, and this is where I think if young students start seeing this now, they're going to be better practitioners when they get out, is that your rib. So we talked about that pelvis being here, the left pelvis, right pelvis, back, is that starting pattern. Well, your rib cage is doing the opposite up top with that left rib flare. So your rib cage walks with your pelvis and they work together. There's almost a chicken and egg philosophical discussion in PRI. Is a pelvis patient a breathing patient, or is a breathing patient a pelvis patient? The answer is yes, but which doesn't answer anything. But
somehow it all stems from the neurological system, though, right? It all comes
from
the nerves.
Exactly.
And I mean, I don't know if you guys have ever treated golfers, but a lot of times in golfers, we'll see that rib flare, and we'll engage in certain techniques. Again, when I was coming out of school, I think I'm older than everybody. When I was coming out of school, we didn't have these concepts like PRI, FMS. We didn't even address really active release. We knew it as myofascial release 4. Our version of Graston was the back of a reflex hammer and some skin lube. So when we were addressing some of these, it still works. When we were addressing some of these kinetic chain issues, really what we looked at was, hey, look, you've got this, left rib flare, and you've got to be able to address this holistically. And really that left rib flare is not really coming from a rib. It's probably coming from, the right side of your pelvis. And this is the reason why.
Yeah.
And so, okay. And so PRI is really the purpose of it, and not to downplay it, but the purpose of it is to, again, encapsulate all this information, say, here's how we're going to be able to describe the phenomenon rather than these independent type examples. Here's everything, here's the entire package. Here's the entire picture.
Yeah.
Right.
Okay.
And I think regardless of whether you're doing a PRI approach, a Yanda approach with the upper and lower cross, I know anatomy training has been brought up earlier. If we're talking about a spiral line problem, we're talking about the same issues. It's just different systems using different terminology. Mm-hmm. And at the end of the day, the goal is to, restore neutrality and improve patient function.
Yeah. One of the best talks I've seen from PRI had all PRI terms deleted out of it. And then essentially people are like, oh, I'm at a lumbopelvic conference. So it's like, you're talking about these mechanics that, again, we're talking about the lumbar spine, the pelvis, all the attachments of muscles all around it and how that orientation works. And I think that's where some of the blowback on PRI comes from, is people just, I don't understand this. You're making up words and you're not looking at what you're talking about. If you talk about it in different terms, it's like, oh yeah, that makes sense. I learned that at the DNS course. I'm like, I know you did. That we're talking the same, the same things.
Yeah. Yeah. Okay. So you've got some people that are listening to this talk, and they're probably have Googled PRI and they go, that looks interesting. And so they want to go take the course. Tell me how much the course costs.
Very reasonably priced, I believe. I'm trying to remember the cost. I've taken a lot of the what are called the foundation courses, and I think those are in the neighborhood between $400 to $600 for the course, and that's an entire weekend, which I think is when you're talking about learning a technique and a therapy. I mean, you can compare that to other courses for a full weekend that'll cost upwards of $1,200, $1,300, $1,400. And so it's very accessible, I think, from a financial standpoint.
And you think it's that accessible because, I mean, I hate to throw a business term here, but you think it's that accessible because the value of PRI is not as large, or it's not perceived as large as some other techniques?
I think it's a perception thing. And, you know, you need to get traction and get practitioners. I mean, if you're driving an institute, getting people into the institute, that's where you find these clinicians that are brilliant and can start doing research and start contributing back to that theory. I mean, athletic training was the same way in its early days. You get these brilliant people that are now producing out of it, but it needed to be accessible. I mean, if they walked in and said, all right, $5,000 per course, it's like, well, for maybe someone who has $500 a year for, you know, continuing ed, they're not going to go to that. And you're not going to further your theories and, you know, practice. So I think that's, sorry.
I was going to say, they also have the home study courses.
Yeah, absolutely.
I did the 3 foundation courses as home study. In fact, the only live course I've attended was the PRI for baseball course. I would say, if for somebody that's looking to get into it, going to a live course it's much easier to understand the concepts. But the home study has value in that, you know, you get 21 days, and I think that it was either $415 or $425. And it's basically a DVD of the live course, and then a course manual and test and that kind of thing.
If I were to make a recommendation with that, it's so myokinematic restoration is, I think, the second foundation course that a lot of people actually take first because it's familiar. There's more biomechanics to it. It makes more sense from our background as athletic trainers. But if I were to make one overreaching suggestion to anybody getting into it, take the respiration course first and do it in person. There's a lot of techniques that revolve around breathing throughout all the courses. And if you have a patient that can't do those basics properly, they're going to have a heck of a time getting where you want them to go. And so actually learning that will be beneficial.
Does PRI educate on sleeping patterns or sleeping postures?
Oh, yes. And I think they talk about that. They have some what are called advanced integration courses. So where we talk about like nuts and bolts of, you know, pelvis position, leg position, reaching with your left arm. Down the line, they have more advanced courses on, you know, basically living patterns and things of that nature.
Hey, listen, if you don't mind, I want to be able to turn it over to Jeremy Jackson. I think he's getting some questions from people that are listening. Is that right,
Sure.
Jeremy?
Yep.
All right.
All right. So Mitch Russell from Tennessee put it up there. So it says, in your research and daily involvement with athletes, have you noticed latent active trigger points in subscapularis causing a large problem in overhead biomechanics? If so, how would you manage this via PRI? And then it says scapular/pectoralis minor release, question mark.
I'll take that one.
Yeah, Josh will have more with that than I do.
The short answer in terms of, do I see these latent trigger points? Yes. Through doing a PRI non-manual, or in some cases manual repositioning techniques, where I'm actually working with this patient's breathing, getting to fully inflate fully get the right apical expansion, I see those trigger points go away. And they may have a little tenderness left over, but once I've restored their apical expansion, the subscapularis trigger points pretty well go away. I haven't seen quite the same release of the pec minor in that case. One technique that I've picked up, I want to say it's Erwin Religioso. I think it's the manual therapist blog. He has a pain-free pec minor release, which essentially is reciprocal inhibition. I give pressure along the pec minor and, you know, have them work into reciprocal inhibition. And I've had really great success with the pec minor release through that.
And I would go one step farther with that and say the subclavius is the gremlin you have to address once you get that pec out of the way. Because if that subclavius is fired up, where it's pulled in, you're gonna start affecting that first rib clavicle function. It's gonna shut you down in that whole neck pattern. And then they're just gonna, like Josh said, they're gonna compensate and start doing this when they throw.
You look really funny just watching it. All right, so I have a question for you on the trigger point thing about the subscapularis. Going through the PRI breathing techniques, theoretically, I'm just really kind of manipulating some efferent and afferent pathways to address pain management. Is that really where it's at?
That's part of it, yes.
Yeah, okay.
It all comes back to neurology.
Yeah.
And
right.
neurological basis.
Okay. We got some
All
other
right,
questions.
so Mitch had also typed in there just to add to his question. In his secondary school, he has noticed baseball, upwards of 70% of shoulder pain is caused by subscapularis impingement, caused by trigger points, scapular dyskinesis, etc. With the aforementioned technique, as well as direct subscapular trigger point therapy, I have noticed these usually relieve the chronic pain. Thoughts on that?
I guess my question in that case would be, does chronic pain come back the next day? Because I've used those techniques myself, and I get I get immediate results. I relieve pain, they go through without pain, and they come back the next day and that latent trigger points return. So, in talking about doing a trigger point release or pec minor release, I do those things before an individual goes out to throw. Kind of what I was saying during the discussion about I don't want to necessarily change their thoracic positioning, because that changes positions of the humeral head and the glenoid. They forget how to throw a strike. I'll do those techniques before they go out, but then I'll follow that up with some PRI-based techniques afterwards to try and make that hold. I don't want to. Treatment's great, making pain go away is great, but I want to long-term relieve and fix problems and not treat problems daily.
And I think with some of the overhead throwing athletes I've worked with, in addition to what Josh talked about, is focusing on the serratus anterior as well, and not just doing scap punches, but it's an accessory breathing muscle. So positioning the shoulder in a way that you can actually breathe and strengthen your serratus anterior without, doing this all day, because how functional is that of an actual movement? And then he took the course with James Anderson, and James Anderson doesn't even refer to it as the serratus anterior. He refers to it by, in Gray's Anatomy, what it's listed as is actually the serratus magnus, referring to its importance in breathing and rib and scapular function.
Yeah. Well, the way I do it with the serratus is inhale and then slow punch, but make sure the pec's turned off.
Yep, that's the hardest thing to do, but that's the best thing to do.
The hardest part to teach, but once they can, it works great.
Tell a pitcher to turn his pec off. They'll look at you like, why?
Yeah, hey, listen, it's been a real pleasure being able to talk to you guys. We got to get back to U of H. And,
sure.
I'm going to leave you with Jeremy Jackson. You guys still talking about this. This is a lot of information. I think probably one of the things that, especially for the young clinicians that are listening, remember you've got this toolbox. And so your goal is to get as many tools in that toolbox so you can address as many situations as possible. If you need to be able to screw in a screw and you've only got a sledgehammer, that sledgehammer isn't going to work. So keep in mind that these are all tools that you can build as a better clinician and, be able to use these tools when needed. I think one tool doesn't necessarily work better than the other, but it's a tool, in the toolbox that's designed to make you just better at what you do. So I really appreciate your time. Thank you guys very much. I learned a lot.
Yeah, thank you.
Thank you.
Yeah. All right. Before I go, I haven't had a plug into the program yet. So remember our Master of Athletic Training program. Hit us up on our website, www.hhp.uh.edu/MAT. Again, www.hhp.uh.edu/MAT. Josh, say hi to Andrew Galucci for me.
I'll be glad to do so. Thank you.
Take care, guys.
All right, so also on a lot of my tweets, I'll mention U of H MAT as we're talking about the SMB. So you can click on there, and I think it has a link to their website on their profile. So if you can't remember, since you're probably listening to the podcast later on. But all right, so I'm going to turn their mics down. I'm gonna move back over to the other one so I can read the other questions there. So thanks you guys for coming out. See ya. All right, I am back. So Mitch says, "Good stuff, mate. Thanks." I guess maybe Mitch is Australian from Tennessee. All right, so Rob has a question that says, with acromioplasty and subacromial decompression surgery, what tissue have you typically seen from a postural restoration standpoint? What issues, not tissue, what issues?
I used to work in the surgical setting, and some of the issues that you would see post that type of surgery is people that if they don't get that scapular position quickly, they develop a compensatory pattern that they try to teach themselves to operate in. That's the biggest problem I see post-operatively when you look at it from a PRI standpoint. And then in Josh's case, when say you have to teach this person to throw again, they've got it programmed in their head how they throw a baseball, but they don't, their body remembers how, or their brain remembers how, but their body doesn't remember how. And so then they get back into that position, and then you start dealing with, like he was talking about, abnormal, labrum frame and things like that, that really rely on that scapular position being proper. That's the biggest thing I noticed from what's really, from an orthopedic surgery standpoint, essentially cleaning the shoulder out. They're not repairing anything, they're removing things. But that's the biggest problem, because again, if there's a little bit of tightness in that anterior capsule based on what you see with anterior capsule laxity, that's not a bad thing all the time, to be honest. So.
Right. And I personally haven't dealt with the acromioplasty, but in terms of dealing with like subacromial bursitis, I see a ton of that in overhead throwers. In terms of dealing with that, it all comes back to scap control, low trap, serratus, being able to maintain that position through and through.
Yeah. And now looking at it from a PRI standpoint, it's like, okay, I'm looking at that, but if they're a right-handed thrower and the athlete doesn't know where his left hip is, it doesn't matter what I do with his shoulder. I can get his shoulder, it looks perfect, but he's not going to be able to transfer that weight through that diagonal plane of force to release the ball. So those are the things that I always found with, subacromial decompression, all the way to working with some Tommy Johns that I've done with in the past.
All right, so you guys may have talked about this a little bit, but I was reading through some of the show notes, and you talk about integrating into all rehab programs. So you said you want to reposition before any rehab exercises so the athlete can work the proper structures during the rehab. But you also said you don't want to do this before they go out and exercise. So typically, if we're doing some sort of rehab or exercise like that, it's going to be, right before they come in before practice, they do the exercises and then go out. How does that look like there for you, Josh, and then you there for you, Mike?
Sure.
Okay. In my case, before they go out, when my guys are doing, their arm care program, just as a general thrower, without getting into any kind of specifics, I'll integrate, and I put this in my notes, what I mean by integrate PRI principles with quote unquote standard arm care is I want this individual to focus on keeping their left obliques engaged, keeping a neutral spine, keeping a neutral pelvis, focus on those things when they're doing, their standard, everybody does their arm care program. And then when they come in after and, do their individualized program, that's when we'll address the PRI and the compensatory patterns.
Yeah.
Right? So during season, they go in and they focus on those things that you said, the standard principles. So during season, and then they go out, they practice, and then they come in afterwards and then do their individualized program. Is that what you're saying?
Right. For the ones that need their individualized program, yes. And doing it that way makes for some later nights for me, but it's in the best interest of the athlete, so that's what I try and do.
So one of the things that kind of drives our treatment philosophy, at least down here, is I shouldn't be treating you for the first time before practice. You should be treating yourself throughout the day before I even see you. So basically that time that's spent after practice all day in class before they even see me, if they're living in a better position based on what we did after practice, I have less to do with them prior to practice. Obviously, that's not everybody, but that's the goal. So sometimes they lead with what we call reference centers. So if I have a guy that has a hard time finding, his left glute, left side, we might just tape his left heel to the middle of his foot a little bit so he feels that, and it equals his gait out throughout the day. So he's living in a better position and turning that switch off. My busiest time with rehab has always been after practice. Never fails. We get a few things to get guys going, but nothing substantial. When we do lifts, they do some non-manual techniques to kind of reposition them a little bit. So when they go into maybe larger movements or things, we know we're putting them in a more, again, you want to lift somewhat symmetrically to help with some strength gains, but that's kind of primarily how we do it as well. We also use it as a recovery technique. Like if we have a really late game, say on a Tuesday, we'll have, a Wednesday morning session where the guys come in and they'll just do repositioning techniques, for 20, 30 minutes and then go back off to class.
All right, so here in the secondary setting, typically, here's how it works here at Pasadena. So the kids will come in, they may have fourth period athletics, so they'll come in and they may do their treatment there. Here at Pasadena, I've seen maybe, like we also have morning treatments. We get here at 6:30, school starts at 7:15. I've seen maybe like 10 kids the entire year that come in for morning treatments because they either ride the bus or they have, the only time they eat breakfast is if they're in the cafeteria. And so they just don't come in for morning treatments. So then fourth period, they come in and want to do something, but, we try to send them out, say, hey, if you're not coming in the morning, if you're not doing anything. So then it comes to now it's 2:30 and we have practice. So then right after then, they're trying to get home. Obviously, we're trying to get home. And a lot of people, a lot of athletic trainers I know here in the high schools, they close the training room 30 minutes after practice is finished. So how do you see is the best way that I can integrate something like this? Obviously, I have to take the courses, but the best way for me and, secondary athletic trainers to integrate something like this to where we don't have the athletes on campus as much like you guys.
Yeah, that's hard. If you can get them to come to the morning treatment a time or two and show them a basic exercise program or a basic repositioning program, the PRI manuals have printouts that they encourage you to make copies of and send home with patients for their programs. Maybe if they could come to morning treatment once a week and you show them the progressions and give them homework and hope that they do it. But that's tough. I mean, I know you guys, in your setting have a couple, just 1, 2, 3 athletic trainers to take care of, 800 student athletes. And that's tough.
Yeah. And I think that non-manual approach is, if you do this in a high school setting where you're going to have to be, really focused on, again, it's home exercise program. And that's what it is. You've got the PRI non-manual techniques, but if you don't know PRI, well, you send a pitcher home with a rubber band program that they do, or, it's the same thing. It's just reinforcing that treating yourself throughout the day will make you a better athlete over the long term.
Okay. So, yeah, that's definitely good. You got to focus on educating and self-treating them, and you can only, I can't stay with them all day and make them do it.
Yeah.
So,
right.
And again, I'm only one person with a whole hockey team. So these guys know that, okay, here's your program. Like if I can't see you, this is what you need to be doing. And then when it's time for, I'm available, then they can come in. But, and we do that just because, again, they can treat themselves throughout the day. We see them for a total of 3 hours, maybe one of those that they're not practicing. What are they doing the other 10? That's what we have to worry about.
Right.
All right, so Mike, you said that you do PRI before pretty much all treatments.
Mm-hmm.
Like we talked last time, I'm looking to do the FMS and then hopefully the SFMA, but all those things will take time and money, over the course of a couple of years. So if I was to pick one, either the PRI or the FMS or the SFMA, which course would you say that I take?
To be honest with you, I would take the PRI courses first, because that's going to give you, so the SFMA will give you an evaluation tool that you can tell maybe where that limitation is and what the problem is, but it doesn't tell you how to fix it necessarily. They've got rolling breakouts and things that can treat certain dysfunctions, but PRI is going to give you, it's going to change how you approach injury. It's changed how I approach injury, and my toolbox has gotten a lot bigger because of it. And I can just tell you from personal experience, I use SFMA daily, but I can fix those problems better because of my PRI education.
All right. So now that you have the skills on all those, what's the kind of the first line of defense? What's the first thing you do to evaluate? Is it using the FMS or the SFMA or PRI, or is it just kind of all blended now at this point for you?
My first line of evaluation, ours is always SFMA, because that's going to give us a top, head to toe global look of how they're moving, and then address those dysfunctions with PRI evaluation. You
feel the same, Josh?
I am not as familiar with the FMS and SFMA, but I can definitely agree that doing the PRI courses is expanding my toolbox more than any other courses that I've done, and giving me different, newer ways to address the problem, where with a PRI understanding, in terms of pelvic positioning, thoracic positioning, whatever, I may then be able to go back and use a technique that I learned as a sophomore in college and apply it in a way that gets what I feel like is a maximum benefit for the patient. So I think that the PRI definitely expands your toolbox more. But again, not being familiar with the others, I don't know if I'm really able to speak on that.
All right, fair enough. All right, do you guys feel like there's anything in the notes that we didn't cover that you really wanted to talk about? Because I know that we had talked about the alignment, like the truck, and you said we'd probably get back to that, and I think we got back to it. But is there anything specifically you guys typed in you guys wanted to hit up?
I think I nailed most of it. Some of these, you could actually do like 2 months worth of hour-long podcasts with specific topics, because it's such a highly because it's integrating multiple systems. So if we just talk pelvis one day, that's just pelvis, that's one system. If we talk pelvic floor, different system. And if we talk about lymphatic, we can talk about vision, we can talk about the foot and ankle. So I think we kind of got the basics down pretty good.
All right, so I got an idea. We're going to start the Mike McKenney hour of the podcast. Got it? So I'm going to sign you up. All right, what about you, Josh? Anything that you...
Always happy to be back.
I guess the only thing that I wrote down, the alignment assignment technique, going back to the truck, and the truck's being driven by the brain. To me, that fits in. When I explain rehab to somebody, I say it's like coaching a defense. It's alignment assignment technique. And to me, PRI is a tool that addresses the alignment and the assignment of the muscles, so that then the technique I'm using can actually work the way I intended to, or the way that anatomy textbook told me back in college that it should. So I guess that's the one thing I'd like to touch on.
Yeah. And also, it's something that I hear a lot from the AT students that come through our program over here, that they get really, really, really frustrated. Like, why am I not being taught this in school? AT programs need to be teaching this. This is an advanced technique. You need a basic foundation knowledge of the human body systems before PRI will make sense to you. And so athletic training students are listening to this and getting upset about that. Stop. You're fine. Learn the basics. And then this is an advanced technique that even clinicians with 20, 30 years of experience that are learning, they get just as frustrated with. So and me too, I'm taking some new courses this year that are probably going to take me right back to frustration land, and I'm going to have to work my way back. And, it's an ongoing process of learning.
I absolutely agree with that. You have to learn the basics before you can learn anything on top of that.
Yeah.
Yeah, I think that's why
you got to have a foundation.
That's why I talk to you guys. You guys are the experts, and I'm the one that doesn't know anything. So, I can kind of bridge the gap between, those people that know some and there's me. So.
And I wouldn't even say I'm an expert. I'm just entry level with PRI. There are definitely, it just go to the clinician side of the PRI's website and start looking at them. And those people are very well qualified to speak way more about this.
I absolutely agree. I don't consider myself an expert at all, but I definitely appreciate being asked to be on here.
Yeah, that was all Mike's idea. So he said, "Hey, get Josh on there." All right. So,
Thank you, Mike.
But
you guys want to give a quick shout out to your programs, and then I'll wrap it up.
yeah, sure. So again, I'm at Northeastern University. Again, we're a fairly large divisional institution that works with our undergraduate program that works with our students here is actually not ours. It's Boston University's, and they have a fantastic ATEP that we work with, great students. So always like to give a shout out to them because, you know, it's a great relationship we have with them.
And I'm at Baylor University. You know, we're in Waco, Texas, about 14,000 students. We do have an undergraduate athletic training program that currently has about 30 students. We're looking to expand to hopefully 35 to 40, you know, through the 3-year professional program. So yeah.
All right, sounds good. So I would say my big takeaway from today is again, moving towards what is the most valuable part of our job as athletic trainers, which we so often forget, because the workshops that I go to, I feel that they never focus on prevention rather than treating or rehabbing or assessing injuries. Whereas if we can learn to focus mostly on prevention, which is what you guys are doing with aligning or with the FMS, you're aligning it, and then, like you just said, alignment, assignment, technique. So again, it's, like I said, a little overwhelming for me because this is all new, and this is my 11th year in the profession, and so I'm still, like I said, once I take the courses, I'll be a little bit more comfortable with doing all this. But I really appreciate you guys being able to come on and kind of break it down for me and anybody else listening. So,
Hey, no worries.
Absolutely, I appreciate being on here.
Yep.
All right, so Rob DeJohn, send me a little feedback saying thanks for the information, love the podcast, keep up the good work. So the Greater Houston Athletic Trainer Society is the one that is responsible for the CEUs for those people that are logged in. So again, ghats.org is responsible for the CEUs. So they're the ones that allow us to offer CEUs for this. And then my wife, she's at home. She usually listens. We have 3 crazy kids, 3 of them under the age of 5. So usually she gets to listen to part of it because they're screaming or needing one thing or another, or lunch or anything like that. But I just want to thank you, Sarah, for your support and encouragement through those times where I really feel like hanging up the headphones, I guess, or the microphone. So I'm Jeremy Jackson on the sportsmedicinebroadcast.com. Almost every single Wednesday we're live. That's again, almost every single Wednesday we're live. You can only see, use, or watch. You can find me on Twitter at PHS Sportsmed. Mike, what's your Twitter?
It's at McKenney_ATC.
Good. And Josh?
It is at manbearfrog, all one word, or you can email me at josh_ogden@baylor.edu.
Okay, so those are also in the show notes that once the episode is published, that'll be on there. So those are already in there. So, and then most of the conversations are the talking points that they hit up. They did a great job in the show notes. So those will be in there too once that's published. Any other way you want to connect to me, you can email me. Again, that's all on the website there at the sportsmedicinebroadcast.com. So for Jeremy Jackson, the Sports Med 1 kids that were here earlier, Dr. Yellen, Nicole Kesha, and Matt Barnes, that's a wrap.
Thanks.
Thanks.
All right, guys. So I'm going to